Good afternoon. I am Emma McGraw-Myers, AARP South Carolina State Volunteer President. It is my honor to welcome you to We Shall Overcome. This is a webinar about the history of health disparities in South Carolina and ways to overcome them. Today's event offers a unique opportunity to celebrate the recent King holiday, notable achievements as Black History Month approaches, and to continue our work on disrupting health disparities. We are pleased to collaborate with Clemson University, Closing the Gap in Healthcare, the South Carolina Department on Aging, and of course, AARP South Carolina to bring you this session. I wish to personally thank you for taking time to join us and to challenge each of you to become active in disrupting disparities here in South Carolina. It is a distinct pleasure to introduce you to AARP's interim State Director, Alice Bennett. Alice is from AARP, Georgia. She holds a Juris Doctorate from North Carolina Central University School of Law and brings a wealth of talent and knowledge. She has graciously agreed to serve as our webinar hostess and moderator. Ladies and gentlemen, welcome, Attorney Alice Bennett.
Thank you so much, Emma, for the warm welcome, and thank you to everyone for joining us today. AARP is one of the largest nonprofit organizations in the country. We are a wise friend and fierce defender on issues that are important to the 50 plus. We reach our members through programs, information, and advocacy. And as Ms. Emma mentioned, one of the biggest initiatives we're doing right now, disparities in health and wealth in minority communities. So today we are here to continue the conversation and build on the wonderful work that's already been done with the publication of 2 health disparities reports from AARP Georgia. So without further ado, I'm going to ask you to join me in welcoming our panelists today, Dr. Shirley M. Timmons and Dr. Thaddeus John Bell. Dr. Bell is a practicing family practice physician in Charleston, South Carolina. He is a fellow of the American Academy of Family Medicine and founder of Closing the Gap in Healthcare, a nonprofit organization created to decrease health disparities by providing health education for African Americans and other underserved communities. Closing the Gap in Healthcare, radio health tips, as well as the website have received national awards from the National Health Foundation as one of the best programs of its kind in the country in 2009, 2010, and 2011. So please join me in welcoming Dr. Thaddeus Bell. Dr. Bell, do you have any opening or welcoming remarks?
Thank you very much. I'm happy to be a part of this forum today.
Thank you so much, Dr. Bell. Our second panelist is Dr. Shirley M. Timmons. She is a professor of nursing in the College of Behavioral, Social, and Health Sciences at Clemson University. She is a certified nurse educator with research interests in minority health, health disparities, HIV/AIDS prevention, church-based health services, and health promotion. Her primary area of interest is design of evidence-based health promotion interventions. So Dr. Shirley Timmons, would you like to say hello and welcome everyone to the webinar today?
Definitely. Thank you so much for this opportunity, and I'm hoping that it can be continued beyond today.
Awesome. Thank you so much. So we're going to just jump right into some of the questions that I have for both of you. And we're going to start with the question, and this might be a little bit loaded, but I'm going to open it up and either one or both of you can answer. And that question is there a connection between 19th century slavery and health disparities today? And if so, please explain. So Dr. Bell, do you want to take that one or Dr. Timmons?
Yeah. Well, it's very well documented that 19th century slavery is very definitely connected to health disparities. Actually, it goes back further than that. but there is a definite connection. African Americans, particularly, were not considered equal. They were slaves, and they in fact were treated as enslaved people. So therefore, their needs were not taken care of. And so as a result, that way of thinking about African Americans that we know of historically actually started around the 16th century and actually got worse, if you can get worse as time progressed. An interesting point is this. In 1968, Dr. King, around the time that he was about 38 years old, made a comment at a conference. And that comment was this, that health disparities would be the major civil rights issue of the 21st century. Health disparities would be the major civil rights issue of the 21st century. And he made this comment around 1968, just a couple of months before he was assassinated. So that kind of puts in perspective how long we've been dealing with this.
And why this conversation is still so very important today. Dr. Timmons, did you have anything you wanted to add?
Definitely, and thank you, Dr. Bell, for that comment. And I'd also want to reference the Robert Wood Johnson Foundation that briefly offers the opportunity to consider that too many people start behind and stay behind because of their color. So that's that short answer. And like Dr. Bell said, the long answer is that folks who were enslaved never had the opportunity to even come close to addressing what we recognize today as social determinants of health. And all of those social determinants of health are related to racism and discrimination. But I want to even back up before we talk about the period of slavery. Over the past year, when we have responded to the issue of George Floyd, when we saw so many people around the world come out to express their anger, their dismay, many people wondered, from where are these people coming? Why is this such a big issue? But history has failed to let us know that people all over the continent have been victimized. Colonialism, imperialism of Europe deciding to go across the world, subjugate folks, enslave folks, and benefit financially happened. And so folks around the world considered that, and they felt that even last year when we had the issue of murdering George Floyd. So I say all that to say, this issue of deciding who will be enslaved, who was looked at as being less than human, came to America, and it was used in order to foster that notion, as well as to gain benefit, financial benefit. And so that whole genesis of where we are today still expresses itself, and it expresses itself as health disparities, as one component.
It's one interesting point. Dr. Timmons makes a very good point. And I will only add this. The phrase, "I can't breathe," that's been going on for a long time. Way before George Floyd. I can't breathe. And I think it's interesting from a historical standpoint that that was the rallying point that many African Americans who had a concept about health disparities really bought into when he said, I can't breathe. So I think Dr. Timmons makes a very, very good point.
We don't separate our history from where we are today. Not only people of color, but I predict people in general, even people who are of other ethnic groups. We have been socialized on this kind of human ladder of value. And we've been socialized to our place on this ladder, and we have bought into that. And so one of the reasons why I always welcome the opportunity to speak of this is so that people can recognize how we have been socialized, how history has been colored, and why we find ourselves today not even recognizing our history and how it impacts us today.
Following up on that question, you mentioned earlier, Dr. Timmons, about the social determinants of health. When you talk about those determinants, how does that impact the health disparities of African Americans in community?
Well, when we consider the social determinants of health, generally we are speaking of 5 major factors. And those factors include economic mobility, educational mobility, access to health and health services, the social capital, how we maneuver through our communities, through society to get needs met, and also the built environment. What is around us, our neighborhood, toxins, air pollution, et cetera, et cetera. So when you look at even 2 of those social determinants of health, education and financial mobility, you also find that those 2 factors are related to health outcomes everywhere. So when we look at the research, we always look at the correlation between that health outcome and education and economic factors. When I have always talked to my students, when we pause on that idea, and so I have to ask them, why is that? Why is that? But when we look at our history, we have had at the most 50 years to develop economically, possibly 50 years to develop educationally because of the Civil Rights Act, in comparison to the majority group that has had around 500 years. And also, we don't recognize that especially those 2 factors are intergenerational. Okay, if my parents, my grandparents were economically stable, economically mobile, then I am more likely to be economically strong. Likewise with education. So when we look at those other factors relative to social determinants of health and look at access, there are reasons why many people, not only African Americans, but people in general, are unable to access health care today. And Dr. Bell can speak more on this. I'll simply say I have to credit the Affordable Care Act with being one of the most comprehensive efforts to foster access to care for more people. Those other 2 factors that I mentioned relative to social determinants of health, and I'll make this really quick, is that idea of having the wherewithal to know how to engage in my community so that I can have a voice. Having resources in my community to help support me in obtaining health care, in obtaining social services. And then that last factor that has to do with the environment. Lack of finances is one of the factors why many people live in areas that are closer to the railroad track, closer to the factory, closer to the pollution. We have to go back in history and also consider redlining. We could not find housing elsewhere, and where we were allowed to afford and buy houses and homes were the less desirable areas. So looking at those 5 social determinants of health and backing out from that to see how we were impacted even in addressing those social determinants of health. So I'll just conclude by saying I'm happy that we at least have identified those environmental factors so we can work on backing out of them, because many people will see individual health behavior as that only factor that dictates whether I'm healthy or not.
So very true. Dr. Bell, did you want to add anything to that?
Well, I think she's done an excellent job in describing the social determinants of health. I'll give you 2 dramatic examples, however. Just yesterday afternoon on the national news, they talked about a county in Alabama in which a lot of people were dying in this community. And when they did the study, they found out that the ground, the water level, was just contaminated with sewage to the point where people were getting very, very sick. That's just an example. In Louisiana, we know that there are a lot of those kinds of environments. Perhaps in our own state, not only are there environments in which African Americans have been forced to live in because of their economic situation, but even the air that we breathe, if it is in an area in which there is a factory, and this factory is just pouring out pollutants in the air all the time, and you're wondering why grandmama or the little baby is always getting asthma or short of breath, then you have to relate to that. Now, one final point. Here in Charleston, we have an area called Daniel Island. It is the opposite. If you go on Daniel Island, you will see no social, environmental determinants of health. You will see sidewalks everywhere. Why is that important? That's important because it sends a message that you can exercise and walk safely throughout Daniel Island. We know that when people are not able to exercise safely, we know that that directly contributes to their health. There are some other things that you will notice also, though. You will notice that there are no billboards advertising cigarettes, no billboards advertising alcohol, no billboards advertising fast foods. You will also notice that there is a world-class grocery store over there. So you can get all of the produce that you want to on Daniel Island because they have this world-class grocery store. So I think it just gives you an idea of what Dr. Timmons was talking about. Those are the social determinants of health. One final point. I noticed that just recently, I got a report from the medical university, and in their report, they're even asking their doctors to document the social determinants of health that they become aware of when they are evaluating the patient. And I certainly think that that's a step in the right direction. I think that's a step in the right direction.
Awesome. Dr. Timmons, did you want to add something else?
I just wanted to say, too, Dr. Bell focused on that built environment. And he did a wonderful job. But just think about that. Sidewalks, lighting, safety, greenery, all of that. So again, I really respect that even one component of the social determinants of health, as well as the others, the one that focuses on social capacity, being able to maneuver within your environment, the idea of racism and discrimination is considered within that one factor. And that is also an area on which to focus as far as eliminating health disparities.
One of the things that Closing the Gap has been focusing on, and that is increasing the number of African Americans in the healthcare profession.
Mm.
That is a major contributor to the health disparities that we are currently experiencing. Black folk represent perhaps less than 4% of the total number of people that's getting the health care. And we now have documentation that when people get health care from folk who look like them or come from a similar background that they come from, they are more likely to be more compliant with the recommendations that the healthcare provider is going to give. The healthcare provider also is more in tune because oftentimes these healthcare providers come from the very area that the patients that they're taking care of. And so they're able to connect to these patients and perhaps do a better job. And then, as Dr. Timmons pointed out, a situation that it is ugly, but we cannot get away from it. And that is racism has profoundly affected the way that medicine has been practiced for centuries, and more specifically for the past 100 years. I'll give you a perfect example. The other day I came across this word called sundown physicians. Perhaps a word for you, sundown physicians. Sundown physicians were doctors of African American descent who could only practice medicine during the Jim Crow era when the sun went down. Because of Jim Crowism, Black doctors were not allowed to practice, even though they were just as well trained as their white counterparts. And it was during that period of time that a lot of African American physicians, because they couldn't practice medicine, but they could practice pharmacy, they could dispense pharmacy. So during that period of time, a lot of physicians practiced in jails, practiced in mental institutions. And so as a result, they got to be very, very good at seeing complicated medical problems that many of their white counterparts would not see as a result of practicing during the daytime. And so they were oftentimes consulted by their white counterparts to help take care of complicated medical problems. So one of the reasons why I think it's very, very important that we encourage young African Americans to get involved in medicine. And I always encourage them. I'm not talking about just being a doctor. I'm talking about in all aspects of medicine, because we need more Black people in all aspects of medicine, on the administrative side, in nursing, in dentistry, in physical therapy, and et cetera, et cetera. So that's what I'm hoping that we will continue to promote. I noticed that just recently, as a result of the pandemic, the studies show that there are a lot of young people applying to medical school and applying to the healthcare profession. I hope, I did not see the data, but I hope that in that data, we will also see more African Americans and other folk of color applying to the healthcare profession, because I think that as a result of that, some of the racism and being culturally competent is going to make some of the health disparities that we are currently seeing go away.
So on that note, I want to ask another question because everybody on this call knows that the story and the tradition and the history of health disparities in African American communities. Do health disparities exist between other races, whites and other races that are not Black? And if they do, are they as exacerbated or are the numbers as large as we see in our African American communities?
Well, I'll offer a broad response, and then Dr. Bell can chime in with specifics. Certainly, we all suffer from primarily the same major health problems. We suffer from the cancers, the heart disease, the kidney disease, so on and so on, in South Carolina and across the country. However, we still have that gap between the white Caucasian groups and the other ethnic minority groups. And that gap is generally wider between African Americans and the white Caucasian group, followed usually by groups that identify as Hispanic and Latino. And I phrase it that way because of how we are labeling folks of Hispanic, Latino identity. So generally, those gaps are broader for those populations, but we all suffer from those primary health conditions. However, there is also the negative reports that we are seeing more chronic disease overall across the board.
Dr. Bell, did you want to add?
Well, I think she's absolutely right about that, but I'm always reminded that every report that I see, particularly when it relates to African American men and health disparities, Black men particularly are furthest behind than any other group of people in the world when it comes to health disparities. And there are a plethora of reasons that I hope we'll get a chance to talk about as it relates to that. But I think that the one factor that seems to play a major role is education and the socioeconomic status of the patient. If those two things are corrected for, the chances of the disparities not existing is decreased. But socioeconomic status and education plays a major role.
Dr. Go ahead.
Yes, I'd like to offer that this is not a simple solution. It took forever for us to have this outcome as far as our health, and it's going to take some concerted efforts around a number of different factors. And what I've been excited about over the past few years is this idea of acknowledging racism as a public health crisis, because that forces us to look at the broader picture and also to look at racism regarding all of these areas, including medicine and early medicine, as Dr. Bell mentioned. He also brought up the idea around providing care when the patient is of the same racial or ethnic group as the caregiver. And I'm reminded of a study by Greenwood over the past couple of years that highlighted and replicated previous findings that newborn Black babies taken care of by white providers died 3 times more than if those newborn Black babies were taken care of by Black physicians. And also within that same report when newborn babies of any ethnicity were taken care of by Black physicians, there was no difference there. So that says so much about what Dr. Bell mentioned as far as the workforce. Again, that is one area that we really need to address, but I also want to focus on something else he mentioned, the role of medicine. And very early on, the role of medicine followed propaganda that Blacks were less than human and that they responded differently to health problems. And we still see some of that today. The early idea that African Americans did not respond to pain, did not have as much pain as other groups. There is a conference that is being convened by Johns Hopkins University in May, and it's called Reckoning with Race and Racism in Academic Medicine. And they are acknowledging how early medicine really perpetuated some of that early propaganda, and how today we're wanting to re-examine that and look at how we can move forward and get out of this kind of chasm that we have been in without addressing all of these issues.
With that in mind, you mentioned several issues about how race has played a part on the physician's care in the past. But, as time travels on, things move on, and racism is still racism, but sometimes the face of that racism is different. So explain some ways that physicians now treat patients differently than white ones.
Thank you for that question. Just a few years ago, we had unequal treatment. And this was a broad survey or study that was conducted really to look at whether that treatment was actually unequal. And the finding was certainly there was unequal treatment in several ways. Even the quality of care provided to African Americans versus whites, the number of amputations are higher with Blacks. There was less recommendations for heart medications, for cardiac-related surgeries, for antiviral medications, for HIV, and the list goes on and on. And that particular document actually highlighted those kinds of differences, even to the standpoint of surgeries that would require testes being removed. So to answer your question, the list is broad, and that is well documented within unequal treatment. And hopefully Dr. Bell can expand upon that somewhat.
Well, I think you made so many good points. One that I would springboard off of your point that you made. Even today, the medical profession is trying to correct data which they have installed in lab values comparing African Americans to white folk and to other people. For an example, and without getting into a lot of detail, the renal function studies. It used to be a variable in there that they had. If you were African American, you could expect that. We found that to be very racist. The same thing when it came to pulmonary function studies. One of the things that has been difficult for the medical profession, and it has been difficult for the medical profession to take a look at itself, but many of the stellar organizations in the medical profession have now come out and said, yes, there has been racism for decades, and we need to do something about it. and it is continuing to affect not only, particularly African Americans, indigenous folk, and people of color. I would point out to you this, a lot of people are not aware of this, but back in 2008, the American Medical Association made an apology to African American physicians for 100 years of discrimination. Wow. I would encourage you to Google it. Did not get a whole lot of publicity. That happened in 2008. As a result of that 100 years of discrimination, that's why we have the National Medical Association and the American Medical Association. Because 100 years ago, African Americans couldn't belong to the American Medical Association, primarily because of racism. All right? That is certainly not the case now. And even the institutions that Dr. Timmons and I represent, our institutions have not always been on board with looking at health disparities. It is only within the past 25 to 30 years that our institutions have really began to look at the disparities. South Carolina still is having difficulty dealing with this issue. That's why it's very unfortunate you do not have, outside of academic settings, you do not have a lot of white doctors talking about the disparities. And the reason that that's very important because a lot of doctors finish medical school not even recognizing that disparities even existed and that it continues to exist. They don't even recognize their own implicit bias. All of that is beginning to change now as we are beginning to look at how these disparities are affecting our population.
Awesome. Thank you. I'm glad that is being looked at now finally because it is definitely needed. I think we have time for maybe 2 more questions before we close out. And this next question, I am going to ask you, Dr. Bell, directly. That's how do you help your parents overcome the effects of health disparities?
Well, I think the pandemic, if there's one thing that the pandemic has taught us, and that is there is a significant lack of information in the African American community. So the way that I have tried to deal with the disparities, and this is why we came up with closing the gap in healthcare. When I was a medical student, I immediately recognized that there was something wrong with this picture. Okay, it didn't take me being in medical school for maybe 3 months, and I recognized, wow, there's a major disparity here. But I thought that maybe it was just something that I was seeing in Charleston, South Carolina. I had no idea that it was global. Okay, so the bottom line is this. That's why I have dedicated my life in trying to educate African Americans and the underserved population, because lack of information is at the core of the health disparities that we see. Even if a person has a health insurance and he doesn't understand that he can be walking around with high blood pressure if he never has a check, he think he's all right because high blood pressure doesn't cause any symptoms until, like Fred Sanford said, you have the big one, then it's too late then. So we try to educate people to try to get them to understand that they need to consider their health in a different manner. And so that's what Closing the Gap in Healthcare has been trying to do for the past 18 years.
Awesome. Thank you. Dr. Timmons, this next question is for you. And this one is near and dear to my heart because I always often wonder, I've read the Henrietta Lacks story, I've read the Tuskegee Airmen story, but even in this day and time, those stories aside, why are African Americans afraid to participate in medical research and clinical trials that might help address some of these disparities?
Well, thank you for that question. And my work has included actually interviewing folks from our community relative to their perceptions about research. And one of the findings that I found most poignant was that even though certainly laypersons are not privy to the process of research, but the response that I got was that if you want us to engage in it, you need to call it something other than research. So somehow there is that perception that has filtered down that research includes doing something to you, okay? And so for me as a researcher, I have learned that the community considers experimental research. They don't think about the other designs, but what resonates with them is someone is doing something to you to test the outcome. And that is primarily related to certainly the negative outcomes of the US public health syphilis study. I intentionally don't call that the Tuskegee syphilis study because that was perpetrated by the US Public Health Office. So folks are still distrustful of the healthcare system. And one part of me understands why, but I've just been surprised at how pervasive that notion is. But again, based on our earlier discussion throughout history, there are so many incidents where we would be smart to question our environment. But we have to certainly find a way to mediate that, especially in light of the COVID pandemic right now. But we need some discussions around weighing the pros and cons, and also the idea of having trusted providers consult with us to weigh the pros and cons. So I hope that I answered your question.
You did, but I have a follow-up for you, and as it relates to the research that you're doing around health disparities. Can you tell us how that research is impacting your work, and what is something that you found most surprising?
Well, so I really focus on individual health behavior. So I am wanting the folks, especially African Americans, with whom I focus on primarily, to recognize those behaviors that we have control over. And those are just a small sliver of behaviors that impact our health, like we were just saying. But I do focus on what we have control over so that we can have some power in putting a dent in those diabetes rates, those heart disease rates, the kidney failure rates, et cetera, et cetera. But I also make sure that they recognize that individual health behavior is just one sliver out of that entire pie. And I also want them to know about that bigger environment in which they function and which impacts their ability to engage in individual health behavior and health promotion. So I want them to know about those social determinants of health. I want them to know the genesis of those social determinants of health so that they don't feel like it's me. What has happened to me? Why is this me? Why is this us? That is a piece that I think if we can address can be an area of empowerment, can help us to be proud of that resilience that we have been able to maintain for all of these years. So I want them to know the bigger picture. I want them to know who we are, and I want them to know who is around us. And I don't mean that in a negative way. I just want them to know the full history.
So both you and Dr. Bell have talked about the history and the educational piece and the need to be in livable communities where people can walk and exercise. So knowing that this is a big issue and there is no simple solution, for individuals who will get an opportunity to watch this webinar, what can you suggest individuals do to start to overcome the problem of health disparities? Just some simple things.
Well, I would recommend that you get to a doctor that you can trust and that cares about you.
Yeah.
All right. It's been my experience. I've been practicing now for 47 years. I've seen a lot of people die who should not have died because they got terrible medical care. Now, I will admit, some of those patients had a personal responsibility to do some things. Some of those patients got terrible health care according to today's standards of practice. And so I would tell folks, look, you get you a doctor that cares about you, that's going to listen to you, and then you make sure you do your part. I'll tell you a quick story. I had a patient a couple of years ago who died from a stroke. Young man died from a stroke. And his wife came in to see me, and she told me, she said, I was cleaning out my husband's, I sold my husband's car, and all those blood pressure medicines you gave him, he never got the prescriptions filled. Found all the prescriptions in the glove compartment of his car. I said, well, yeah, I already knew that. I said, but I can't, because of patient-client confidentiality, I can't call you and tell you to monitor him. But I already knew that he was not doing what I had recommended for him to do. So that gives you an idea that patients do have a responsibility to do what doctors recommend. And I think that this vaccine hesitancy and vaccine resistance that we are currently seeing is a perfect example of that. That's just one.
Thank you. Dr. Timmons?
And I certainly agree with Dr. Bell, and having that social support network, including your healthcare providers, and also to be aware of what impacts that healthcare provider and the system within which that healthcare provider operates. And that is very much related to policy. And so for folks to try to zoom out and step back and look at what is affecting my health care services, not only the providers, access to medications, transportation, all of those social determinants of health, and work on being able to have that conversation with our politicians and certainly vote.
Yes, that is so very important. And I'm hoping that we eventually get a voting rights bill passed here soon. I hope. This has been absolutely wonderful conversation. Timekeeper, how much time do we have? I don't want to overgo our hour, but while we're waiting for her to give me that information, for those of you who are listening, we talked about early on in this webinar that South Carolina has published 2 reports on disrupting disparities. Those 2 reports can be found at the AARP South Carolina website. So please take the opportunity to go out to the website to find that information. The website is aarp.org/South Carolina. And with that, I think we might have time for maybe one more question. And I don't want to butcher the name, but why do historians refer to J. Marion Sims as the Joseph, is it Mengele of the American South?
Because
Joseph Mengele. Excuse me, it's Joseph Mengele.
Thank you. Thank you very much. Mengele.
He's the monster of the Midway.
Oh, wow.
J. Marion Sims is a graduate of the Medical University of South Carolina. He operated on African American women against their will, oftentimes without anesthesia. In South Carolina, he's pretty much revered. There are 1 or 2 buildings named after J. Marion Sims, I think up in Columbia. Just recently in New York City, there was such a revolt against his statue in, what's the name of that park in New York City? The main park? I'm blanking on it.
Bryant Park.
Bryant Park?
Is it Bryant Park? Yes. They had his statue taken down, but he is one of the he is a person who we do not want to celebrate because of his attitude as it relates to African American women during the time that he practiced medicine. And I think it was around the mid 1800s.
Wow. Thank you for that. And I'm sure that's probably new information to some people. And that's very good information to know. Last I saw, I think we had 10 minutes before we wrapped up, but I want to also give you an opportunity to make any closing remarks that you want to before I turn it over to Ms. Kay Hightower to close us out with thank yous and closing remarks. So Dr. Thaddeus Bell, would you like to close us out with some remarks?
Well, first of all, I want to say thank you very much for inviting me to be on this panel today. Thank you very much to Dr. Shirley Timmons. I've never met you before, but it was certainly a pleasure working with you today. I would emphasize that health literacy is very, very important. Keep in mind that only about 12% of the population who have health issues really understand what those health issues are about. And as a result, they make very poor decisions regarding what they eat, what they drink, physical activity, and behavior. And I think that that's why it is certainly contributing to the vaccine hesitancy and the vaccine resistance that we are currently seeing today. I would encourage people to get their vaccine, get the booster shot, practice social distancing, wear the mask. You know, they changed the mask, and now we're getting rid of the cloth mask, but we are wearing the N95 mask. So be sure and wear those. So that would be my final comment.
Thank you, Dr. Bell. Dr. Timmons?
Well, I also want to say something about J. Marion Sims before my closing comment. And I note that when I first went to undergraduate school at USC, I lived in the Sims dorm. I had no idea who J. Marion Sims was, but I wish that I did know that history, and I wish that I did know my history in order to be a louder voice in raising the issue of why are we still experiencing saluting folks who did so much harm. And J. Marion Sims was certainly one of those people, but also I recognize that he was not the only one. There were many, many, many more. So my lasting comment is that I certainly appreciate this opportunity to share and to listen and learn from Dr. Bell. My hope is just that every person would just do as much as they can do to manage their own well-being and to also be verbal in addressing the well-being of others. We have become such a divided country, a divided community, especially over the past few years, but we can be better as one people. And I do believe that if we can reckon our history and understand where we are today, that we can be better. So that is my hope for everyone going forward.
Thank you. It has truly been my honor to moderate and host this conversation with both of you today. I grew up born in Greenwood, South Carolina, but I left right after I graduated from high school. So I did not know the story of Dr. Sims. So thank you for that as well. It has been a great pleasure to meet you both. Thank you for being here. Thank you for participating in the panel. And I'm now going to turn it over to Kay Hightower to close us up.
Thank you. This was absolutely marvelous. I'd like to thank Dr. Bell and Dr. Simmons for their phenomenal presentations. And of course, our good friends at AARP. We welcome back to South Carolina, interim president or state director, Alice Bennett. Your moderation was phenomenal. And as always, wonderful to see my good friend, Miss Emma, who has done such a great job and presented such great leadership for AARP. This was wonderful. I think you expressed magnificently the history and ways to overcome by finding a good doctor that you can trust, by policy, looking at the systemic situation about voting, the connection between voting and healthcare. And as Dr. Timmons put it at the end so eloquently, looking out for each other. It takes a village. We all need to work together. So I want to thank you, AARP, the South Carolina Department on Aging. We love working with you. And this has been truly a pleasure. And this could not have been put together without the two Joes. Joe Myers, Joe with an E, who is the, I would call it the Zoom master, but I think it's the StreamYard master. And of course, without the leadership and friendship and guidance of Joe Pauling Jones, she is just a delight to work with it. So 3 cheers AARP for the two Joes, one with the E and one without. Thank you so much.
Thank you so much. Ms. Emma, did you have any closing comments?
I did not. I just would like to remind everyone of the challenge that moving the needle forward on health disparities rests in each of our hands. And we challenge you to make a difference and to be the difference. Thank you again, Dr. Timmons, and of course, Dr. Bell.
Okay. Thank you, everyone. With that, I think we will close out. Thank you again for being a part of the panel today. It has truly been an honor. Thank you.